Good morning, friends. I hope you can hear me. And I've checked my screens before. I hope you can see the screens as well. If not, if someone can just shout out whether you can or cannot see my screens.
Dr. Herwadkar, everything is fine.
Excellent. Okay, so we'll change our focus now from the neural structures. We are going to now start with vascular imaging, and today the emphasis is on the arterial imaging. And hopefully, what I wish to share is the fact that when we talk about arteries, vessels in general, we think about them as pipes communicating between the heart and the various organs. But in fact, they are not just these inanimate objects, but they have got their own life and they have got their own physiology and functioning, of course, which we know. And this is never better, more exemplified in CNS, where they form independent units, the neurovascular units inside a functioning cell or functioning section of the brain, and that is what is sets the neurovascular unit separate from the units elsewhere within the body. Though we have changed the focus, I don't think the path is going to be any different. I'm going to try and share the same ideas that I have about imaging about any body part. As we have talked about, we have looked at how the organ develops. We have seen how it has evolved over millennia and how it is now presenting it to us. So when we see a structure currently, we have to try and trace it back to the roots as to why it is in such and such fashion. So that's sort of the preamble, if you like. So let's go back to the roots. Right. So the fundamentals of this symbiosis. Why do I call this symbiosis? Because the brain, the developing neuron, the astrocytes, the glial cells, and the developing blood vessels, they are kind of emerging in parallel with each other. It's not as if the brain has developed at certain stage up to 3-4 weeks and subsequently gets impregnated with the blood vessels. That's not the case. In fact, the development occurs in parallel as the nervous system patterning is occurring, and we have seen this patterning in our discussions on embryology. Similarly, the vascular system is developing along the same lines. And these blood vessels need the developing brain to direct them, but at the same time, the developing brain needs the nourishment initially via diffusion, but subsequently via endothelial line channels. And it's very essential we understand this intimacy between these two structures, and it's nowhere else as exemplified as in the as we talk about the blood-brain barrier, and this barrier is so specific in the neuronal structures that we don't find it anywhere else, and it's so essential to understand how it uh, develops and then functions so as to protect this fragile nervous system from the excesses, from the aggression of metabolic changes or infections or cellular aggressions. Also important to realize that these symbiosis is what is so essential in all of these modern parametric imaging paradigms. So for example, in functional MRI or in perfusion imaging, it is this assessment of the functionality of this blood-brain barrier that is so essential. And perhaps you may have listened to this, some of this in the previous discussions with Dr. Chauvin. He may have discussed with you what happens when there is a dysfunction of this blood-brain barrier with tumors, but also not just tumors. It is also a hallmark of other diseases when it gets when it's imbalanced, like for example in vascular malformations, for example in vascular dementias. So very essential to understand that this is a very special relationship that exists. So how does it develop? Okay, so like any organ, we have got what we call as angiogenesis and what is called as vasculogenesis. So angiogenesis is the earlier aspect of it, when the progenitor or the pluripotent cells will start under the influence of various morphogenetic proteins. And we have talked about the morphogenetic proteins being released by the neural tubes, which are different for the dorsal aspect, which are different for the basal aspect, which are under the influence of notochord, under the influence of neuroectoderm. So these morphogenetic proteins will act upon these developing progenitor cells, which are the angioblasts. And these angioblasts, which are then going to secondarily invade into the neural tube. Where do these angioblasts come from? Well, they come from the mesoderm, typically the lateral plate mesoderm. That's where they come from. And they are invading into this developing neural tube, which itself is developing a specific pattern. What do I mean by that? Well, now this neural tube is recognizing in itself that it's got a medial surface or the PL surface. It's got a lateral surface or the medial surface, which is the ventricular surface, the lateral surface, which is the PL surface. Similarly, the neural tube is recognizing that there is a dorsal element to it, there is a ventral element to it. So as the neural tube itself is developing this patterning, so do these angioblasts realize that, and they will start penetrating into this developing neural tube. And hence there is this dynamic equilibrium which occurs between these vessels and this developing neural tube. And this invasion into the developing neural tube occurs at a very specific time, very time control. You have to understand most of these vasculogenesis and angiogenesis occurs within the first 7 to 8 weeks, so it has to be very tightly time controlled. Not only that, it also determines that the developing neurons will determine what point are these specific capillaries, blood vessels going to penetrate into these developing neurons. And in a sense, this budding capillaries will then uh, uh, perfuse the developing brain. So the brain itself, the neurons, is governing how it is going to get perfused. And of course, any insult to that is going to change the way these blood vessels are going to form. And if it occurs very early in life, it is going to have a profound effect. It affects much later during embryogenesis. The effect is going to be small related to the area affected. And these developing blood vessels, they recognize these patterns that are developing within the brain. They will recognize the various aspects of the neural tube, and hence they will themselves have a specific pattern developing. And we'll look at these patterns in a minute. And these are called as segmental vessels. So they realize that there is a neuromere, there is a rhombomer, and hence these blood vessels follow that specific pattern. And these lead to these eventual functional domains within the brain parenchyma. So you then develop into the pharyngeal arches, the hyoid arches. You get all the rhombomeres we talked about in the development of the brainstem. And that's how these blood vessels allow the perfusion to that particular somite. Once they have invaded, and this is something we have discussed about before as well, just to show you what this is showing really. So imagine this is a cross section, with this being the PL surface. This is the developing ventricular zone. This is the ventricle here. So all the cells which are going to develop, the neuronal cells, are going to start around from here, the neuroblasts, and then they're going to migrate along these radial cells and layer themselves on the cortex. And they are under the influence of these radial cells, which are basically glial cells. But these glial cells also have a very relevant function in allowing the developing endothelial cells. Remember, they are on the outside yet, they have yet to invade, and then they allow the migration of these endothelial cells towards the ventricular zone. And over here, the endothelial cells will proliferate, and from there they will then radiate again back towards the outer surface, but also tangentially and longitudinally, to then subsequently form the entire vascular structure. And this is just again to remind us what is this blood-brain barrier. You may have looked at this last week. On the surface blood vessels, this is a PL artery, this is a sulcus, this is a gyrus, and you can see these surface arteries have got thick muscles over here. They are multicellular. But as you go more and more deeper, much more peripheral, much more inside the functional unit of this neurovascular structure, you'll realize that this lumen is surrounded by a single endothelial cell, and the single endothelial cell, which is this blue cell over here, is then subsequently surrounded by another cell, the pericyte, and that controls the this unit. And the integrity is further enhanced by the footplate of these astrocytes and the surrounding glial cells as well. And this constitutes the blood-brain barrier along with the tight junction. And of course, any disease, be it infection, inflammation, or tumor, which is going to disrupt this blood-brain barrier, is to connect. It will create fenestrations and allow uh, 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 passage of abnormal structures, high osmolar structures, which normally would have been stopped by the blood-brain barrier. And this allows us to image, of course, how the particular abnormality behaves, but also explains how the tumor spreads too. And finally, this is also a paradigm on which we base some of the treatment aspects. So this is kind of sort of the background about the structure of the neurovascular unit and how it develops. But if you look at the pipes themselves, and this is very, very relevant, and those who are really interested in understanding the embryology, I would really recommend to you to read Professor Les Junius. He's dedicated his life to the understanding of this. He's written volumes of this, and if you haven't got enough time, then certainly try and look into this web page created by Dr. Shapiro and his colleagues. This is something that I have borrowed from that. It's an excellent depiction of how the neurovascular structures have formed in us, but also gives us a great insight as to how they have developed subsequently over years, over millennia, from fish to the current Homo sapiens. And I shall try what Pierre Les Junius has done over his lifetime to try and give a succinct summary over the next 3-4 slides. So just bear with me. So this is a functional unit, and we use the spinal cord because brain is nothing but just a highly evolved spinal cord. So we have got a spinal cord with the dorsal aortae, which are developing on either side. And this dorsal aortae, and we talked about this segmental patterning under the influence of morphogenetic proteins from the cord. The segmental vessels will start developing. The segmental vessels will develop interconnections between them. They will also fuse in the midline, and that becomes the anterior spinal artery. And most of these segmental vessels will regress. Only a few will remain in behind, and hence we call the anterior spinal artery, which may originate either from the vertebral artery in the cervical region, or from the multiple thoracic intercostal vessels, or the lumbar vessels too. So this is kind of the basic structure, if you like, of how the various metameres develop and give rise to the development of the blood vessels perfusing the neuronal structure. And we call these as the radicular arteries, which supply the cord. So as I said, the brain itself is nothing but a continuation of the spinal cord. So we have looked at this before, the cord, and then we get into the various processes of the brain. You've got the prosencephalon, the mesencephalon, and the rhombencephalon. And remember how everything was much more concentrated right at the forebrain aspect earlier on in the early fishes, where the olfactory apparatus was the more dominant aspect of it. But similarly, the blood vessels patterning follows exactly the same path that it did in the spinal cord. So you still have the dorsal aorta on each side, and the segmental vessels which join together to form the supplying blood vessels. But what is specific that happens in the brain itself is that this dorsal aorta, which is subsequently going to form parts of the internal carotid artery. So remember, now this is some of the internal carotid artery. I've kind of bypassed the development of the cervical internal carotid artery. We'll concentrate on the intracranial bit. So the internal carotid artery, we talk regularly in terms of dividing into the MCA and the ACA, but embryologically actually it divides at the level of the posterior communicating artery. So that becomes the cranial division, and that becomes the caudal division. So the caudal division is nothing but the posterior communicating artery. And the reason to understand that is because the developing hindbrain is actually perfused by the internal carotid artery, with the blood flowing from it via the caudal division, and actually flowing from superior to inferior, as opposed to in adults where the basilar artery is mainly supplied by the two vertebral arteries. But understand this, that this communication does not occur till late mammals, and in early mammals, almost up to the sheep, the blood flow occurs in that direction. So this is the basic paradigm. The internal carotid artery divides into the cranial element, and the one of the major arteries is this medial stride branch, which mainly supplies the olfactory apparatus. The lateral stride branch, which will eventually form the middle cerebral artery, is a much more smaller branch. And if you see in much more earlier fishes, this is almost non-existent. As the cerebral hemisphere start to develop, and this we start seeing in the reptiles, in amphibians, and subsequently in avians and the mammals, the the lenticular stride branches will start getting bigger. So the MCA is nothing but a derivative of this lenticular stride branches, which has evolved much more later on in life, just about 2 million years ago. And this is just to show again what has happened between the fishes down to amphibians to reptiles, and reptiles to birds. And I don't really want to go into the too much of the complexity of this, but try and understand that the middle cerebral artery is branch of the lateral stride, lateral olfactory artery, which develops later on because of the increasing demands of the growing neocortex. And understand again the fact that the posterior communicating artery, which is developing from the as a caudal branch of the internal carotid artery, is still not joined up with the vertebrobasilar system. And here we are still in the birds, where you can see the direction of the flow in the posterior communicating artery in the upper basilar is in that direction. And subsequently in mammals, this communication stops, changes the direction, so and so that in late mammals, almost after sheep, around dogs, that's where we see that the flow within the basilar artery is now antegrade, and the posterior communicating artery is then in balance with the basilar artery. And hence the reason to understand as to why sometimes the PCOM, if the PCOM is big, the basilar artery is small, because the function of the basilar artery, especially the supply of the PCA territory, is then taken over by the PCOM artery. And that's why it's so important to understand these embryological principles. Right, so that was kind of a brief background, if you like, as to how things have evolved over the phylogeny. So let's look at the traditional concept and try and understand this intracranial circulation. So of course we talk in terms of the anterior and the posterior circulation. So the anterior circulation is the internal carotid artery and its branches, and the posterior circulation is of course the vertebrobasilar circulation and their branches. I haven't really discussed various imaging modalities, and the reason is because we can use each one of them depending upon the availability, of course, but also what you're trying to understand. And this is just a CTA angiogram, just to show you that CTA angiogram can show you the arch anatomy very well, can show you the origin of the vessels coming from the arch, if there is calcification, and also if there is an stenosis. So for example, here this is a subclavian artery, this is the left common carotid, and here we have the brachiocephalic trunk over here with the right common carotid. Normally we would see the right subclavian here, but because of the contrast administration, we don't really see the details of the right subclavian artery. And of course, you can reconstruct them in various planes to show the bifurcation, to show the origin of the various arteries, so on and so forth. Similarly, you can do it with the MRA as well, and this is contrast enhanced MR angiogram as opposed to a time of flight MR angiogram. Time of flight does not need injection of contrast routinely, but in contrast enhanced MR angiogram, you can obtain imaging from the arch to the circulophyllus. It is optimum to look at the neck vessels much more elegantly. So here you have got again the similar understanding here of the arch anatomy with the brachiocephalic trunk, the common carotid arteries, the bifurcation of the arteries, the distal cervical, and then the subsequently intracranial vessels. And of course, you can segment these vessels and try and evaluate each one of them in turn. And here, for example, is a MIP of the lateral view of the common carotid artery showing the bifurcation. And you can measure these various segments to determine if there is any stenosis at any particular level. And finally, this is a time of flight MR angiogram, which is good to look at the intracranial vessels, especially for aneurysms. Certainly at our institute, we tend to use them for investigating intracranial aneurysms. Not necessarily someone who's had a subarach, but certainly for someone who's had a subarach and who's had it treated and as a follow-up, or sometimes in patients who cannot have CT angiograms, or if you are expecting to do follow-up MRIs on a routine basis for someone with high family history of subarachs. So in these cases, we would do a MR angiogram with time of flight technique. So let's look at the anterior circulation in detail now. So this is where we are going to go into a more detailed understanding of the blood vessel structure itself. So if you look at the internal carotid artery, there are various classifications which describe the structure of the internal carotid artery. And this is one which is found in the surgical literature, and this you may find in the endovascular literature. And basically these are to identify specific segments, and of course the surgical classification used it to identify the surgical access to the structures, while endovascular was based on the identification of the various blood vessels. But in essence, basically it is to talk about the course of the artery as it comes through the neck, and hence that's the cervical course, then through the petrous segment. A segment called as a lateral segment is just between the petrous and cavernous, which we don't necessarily see on imaging. Subsequently the cavernous, of course, and then the artery kind of curves back on itself, what we call as a carotid siphon. And this is where you find the first branch, which is the ophthalmic artery. And that's a very, very important landmark to understand, because this is the point where the artery is going to penetrate the dural ring. And the relevance, of course, is that once it penetrates dural ring, that's where the artery is then exposed to the subarachnoid space, and any aneurysms from and beyond ophthalmic artery are at high risk of producing subarachnoid hemorrhage, as opposed to any aneurysms beneath that dural ring. And that's of course a very broad concept. Aneurysm rupture itself has many other determinants apart from the location. And subsequently beyond the ophthalmic, then you come into the posterior communicating artery segment over here, and then the choroidal artery, which is just behind the posterior communicating, and then the carotid then the part of the artery between the carotid and the carotid T, or the carotid termination. And this is how the anatomy would look like on an angiogram. And we'll try and look at these various segments, rather than laboring too much upon the differentiation itself. So let's look at the anatomy again in the AP and the lateral, and I've left here again, this is the bony landmark just to show you. So the cervical course is of course within the neck, cervical course. Then we have got the petrous course, which goes to the petrous bone. You have got the petrous bone here, dense bone with the mastoid here at the back. You can just about see the external auditory canal. And this is the carotid artery as it courses. It's got a vertical part in the petrous, and then the horizontal part. And then this is just about where we would see the lacerum, and then the cavernous segment. So this is the cavernous segment over here, which is really on either side of the midline, and that's the cavernous portion. And subsequent to that, we get the internal carotid artery, which is seen here on the AP as something which is pointing laterally just about here. This is the ophthalmic artery, and it's easy to identify it, especially if you can see the orbit. And then the posterior communicating, which is the largest branch, which goes posteriorly, but on the AP it is much more medial, which is here, as you can see. So this is a posterior communicating artery, and which you can sometimes see superimposed like over here, depending upon its dominance, as if it is coming from a branch of the from the carot MCA. But the PCOM itself, as we know, is a branch coming from the internal carotid artery. It's just superimposed itself on the carotid termination. And then subsequently the artery which is just distal to the PCOM, which is the anterior choroidal, which is the small artery which has this characteristic bend on itself, and then slight increased density as it then enters the choroidal fissure, and then the temporal horn. And so that's the anterior choroidal itself. And you can, the other important bony landmark to identify apart from the petrous bone over here is the clinoid process. Extremely important. I've identified the ophthalmic artery, and it's very important to assess where the ophthalmic artery is in relation to the clinoid process itself. Because the aneurysms beyond that, or the segment beyond that, we sometimes refer to as the supraclinoid segment of the internal carotid artery. And a very, very important surgical landmark as well when we are operating for abnormalities around this area, because you have to then identify the location of the ophthalmic artery and the PCOM to judge the exact location of the dural ring. If you look at the branches of the internal carotid artery, there are quite a few over there. And I don't really want to go into too much details of it. And some of them, most of these probably do not really matter in day-to-day life when we look at an angiogram. But occasionally, especially when you have got occlusions, especially when you have got AVMs, or you are embolizing a tumor or a fistula, that's where it's very, very important to identify these branches, not only because they may be supplying the abnormality, the tumor or the fistula, but also these are the potential anastomotic sites whereby some of the external carotid can plumb in into these arteries and can be a source of problems, because most of the embolizations are done by the external carotid system for tumors or for fistulae. And if there is any artery which is communicating with the internal carotid artery, then these are potential risks of embolization into the leptomeningeal vessels. We have got all of these branches, and we may I will share some of these in due course. So for example, in the petrous segment over here, you have got the caroticotympanic and the median artery. The lacerum does not really have any branches. The cavernous segment has the various trunks, and we look at them from the clinoid. Just beyond it, you typically see the ophthalmic artery and the superior hypophyseal, and then subsequent to that in the C7 segment is the posterior communicating artery. So looking at the cervical internal carotid artery, we know that these are located within the carotid sheath, with the artery medial, the vein lateral itself, and they just lie lateral to the thyroid lamina and deep to the sternocleidomastoid. This is very relevant for surgeons who practice endarterectomy. And it's important to realize that this sheath itself, apart from containing the arteries, also contains very important neural structures, like for example the glossopharyngeal nerve, the accessory nerve, but also the branches of the vagus nerve, which we have seen in the past, are very, very closely related to this to the carotid sheath. And this is a patient who's had previous a surgery in the upper mediastinum with a damage to the recurrent laryngeal nerve with the resultant vocal cord palsy. And here you can see that the vocal cord is deviated medially. And sometimes the internal carotid artery itself can be quite medially placed. For example, over here, you can see they are almost kissing in the midline just behind the pharynx. And that can be a dangerous proposition, especially in children who may thrust an object to the back of the throat, for example, a pencil, and that can have disastrous consequences. Regarding the neck vessel imaging, of course, you can do a MRA. For example, this is time of flight, this is contrast enhanced. And just to highlight how contrast enhanced MRA is much more useful in analyzing the morphology of this carotid bifurcation. This is external carotid with the branches, because you can then see not only the stenosis, which is of course is relevant, but you can also see these ulcers which have started to develop, making this plaque, which is here, which is this filling defect, a much more fragile plaque, which is higher with a higher risk of embolism. And this is a slide which just to depict the importance of various modalities. This is a DSA, this is a MRA, and this is a CTA. And of course, each one of them have their own role to play, though in terms of imaging of the carotid bifurcation, we hardly ever do carotid angiography now. Most of the patients will get either a Doppler examination, which can be supplemented with either an MRA or a CTA. One of the problems with Dopplers, of course, if there is extensive calcification, for example, in the CTA, these plaques will prevent adequate visualization of the carotid artery and the lumen, and hence CTA or an MRA can be more useful in that circumstances. Certainly, if a patient is being worked up for endarterectomy, it's not unusual to have a supplementary examination, either an MRA or a CTA, apart from the Doppler itself. Towards the petrous ICA, the petrous ICA, as I said, is encased within the petrous bone itself, and it's got this horizontal segment and the vertical segment, and the horizontal segment leads itself towards the cavernous sinus, and this is what has been shown in this patient over here. And if you look on the MRA, this is what the carotid artery will look like. This is in the vertical portion, which is this part of the petrous bone. Over here, you can see the phlovoid, the plaque. These are the retropharyngeal structures with the muscles prevertebral muscles over here. This is a foramen magnum. So this is right at the skull base, at the origin of the petrous part of the internal carotid artery. And just to highlight an example of a dissection in the same patient on the right side, this high signal is intramural hemorrhage within the wall of the artery, which has resulted in dissection. And this is a contrast enhanced MRA of the same patient. Here you can see the carotid artery with the lumen nicely, elegantly shown. But over here you can see the narrowing within the artery with the irregularity within the caliber caused by the intramural hematoma or the dissection. Uh, uh, the branches of the petrous are very small, and for practical purposes you don't really necessarily see them during routine angiography, but sometimes, especially if there are tumors, for example a glomus tumor in this area, these arteries will become big. And some of the arteries, for example, you have got what we call as the caroticotympanic branch. This is a pictorial representation of that. Can anastomose with the inferior tympanic artery, which is a branch of the external carotid system. During embryogenesis, sometimes these arteries can anastomose with itself, especially if the internal carotid artery has not developed normally. And what you do get then is this anomalous course, which is basically an anastomosis between the caroticotympanic branch of the distal internal carotid and the inferior tympanic branch of the external carotid, giving rise to this anomalous appearance, which is shown in this patient over here. This is a normal course of the left internal carotid, should be somewhere around here, but here you have got a much more lateral course compared to this one. These are the inner ear structures, the cochlea. You can see where the carotid is in relation to that, and you can see where the carotid is much more lateral and much more posterior because of this anomalous development.
Dr. Herwadkar, we can't hear you.
Can you hear me now?
Yes.
Yeah, sorry, apologies. Okay, so now we have we are at the cavernous sinus level here. So the cavernous sinus itself, on either side of the sphenoid sinus, sella itself, the dura NK structure, which contains the venous plexus, but also contains the internal carotid artery. So this is the cavernous portion of that artery, and but also it contains this relevant nerves: the third nerve, the fourth nerve, and the first and the second division of the ophthalmic of the fifth nerve, but also the abducens nerve, which lies within the lumen itself of the cavernous sinus. And we have looked at this anatomy when we discussed the cranial nerve anatomy. So the cavernous carotid artery branches over here, and these again you can see sometimes, for example over here you can see them during angiography. They are seen as very thin and flimsy branches, the meningohypophyseal trunk and also the inferolateral trunk. The meningohypophyseal is much more posterior, the inferolateral trunk is more anterior. And even though these are very small, again they are very relevant, especially during pathology when there is a development of a fistula, for example, or tumor. For example, here this is a patient who's got a vascular malformation around within the right hemisphere, and you can see it's supplied not just from the leptomeningeal vessels, the choroidal arteries, but also has derived branches from the cavernous portion and the petrous portion of the internal carotid artery, supplying that vascular malformation. Uh, these arteries are also very, very relevant during the development of the ophthalmic artery, and we'll come back to that in the next slide. But here you can see that there is an anomalous ophthalmic artery. Normally the ophthalmic artery will come off much more distally from the internal carotid artery, somewhere around here, but here the ophthalmic artery has actually come off from the cavernous segment of the internal carotid artery, which is actually the inferolateral trunk. So the inferolateral trunk, which is here, also is a precursor of the future ophthalmic artery. And we'll look at that in the next few slides. Some of the pathologies, I don't want to labor too much on the pathologies. I think Dr. Hilditch will talk about the pathologies, but it's important to recognize the flow voids, which is what we have to see when we look at the pathology absence of flow void suggests, of course, thrombosis or very slow flow through that vessels, or the vessel can be very, very big. For example, you have got an aneurysm of the cavernous carotid artery. And also sometimes these are uncommon pathologies, but we see them at Salford because we get referred them from the eye hospital, from the neurologist, is the fistula. And this fistula can be either direct, when there is a direct rent from the cavernous carotid artery into the cavernous sinus, or indirect. For example, here you have got multiple small branches of this meningohypophyseal trunk, which are then dumping their blood into the cavernous sinus, and from there the blood is coming anteriorly via the superior ophthalmic vein into the orbit, explaining why this patient would have proptosis and pulsatility and ecchymosis, because it is getting directly blood from the arterial system. For those of you who are interested in skull base and pituitary surgery, you will know the relevance of obtaining routine CTAs and high resolution MR scans to understand the invasion of the cavernous sinus, but also the position of the carotid artery in relation to the tumor itself, and hence the necessity for doing CTA brain lab examination for these patients to understand the anatomy of these vascular structures. Moving on from the cavernous now to the ophthalmic part of the carotid artery. So this is the clinoid process I mentioned earlier on. Very important to identify the clinoid process, because this is the part of the artery which is just next to the clinoid, and here you can see the ophthalmic artery just arising from that portion, and that can be variable exactly as to where it arises. It can arise in the supraclinoid portion or in the paraclinoid portion, but wherever the carotid the ophthalmic artery is seen, just beyond that, you will have the carotid artery piercing through the dural ring, and hence any aneurysm at or beyond this level have the likelihood possibility of causing subarachnoid hemorrhages. And of course you have got a CTA, but you can see it also on an MRA, but on MRA it is difficult to identify the clinoid processes clearly unless if you're used to seeing them, but hence if you're contemplating any surgeries around this area, it is so vital to look at a CT picture of that region. This is a rather tedious slide of the ophthalmic artery. Just to orient ourselves, this is the globe. This is the developing internal carotid artery. This is the anterior cerebral over here, the cranial branch of it. This doesn't show the middle cerebral artery. So normally the ophthalmic artery is derived from two parts, the ventral and the dorsal ophthalmic artery, and the ventral ophthalmic artery comes actually from the anterior cerebral artery. So this is something worth remembering, that sometimes, very rarely, the anterior cerebral artery can give rise to the ophthalmic artery, and of course it goes through the optic canal. The other part of the ophthalmic artery is derived, especially the one which supplies not the retina itself, but that which supplies the muscle and the supporting tissue, comes from the dorsal ophthalmic artery, which is a branch of the inferolateral trunk, which comes from the cavernous portion, and that goes via the superior orbital fissure. What happens in later life is these two branches, of course, will anastomose themselves just within the orbit, and the ventral ophthalmic artery will then subsequently migrate and then arise directly from the supraclinoid or the clinoid internal carotid artery, and the dorsal ophthalmic artery, which has come off from the cavernous portion of the internal carotid artery, eventually regresses, and then hence we get subsequently the adult form of the internal carotid artery, which comes from the supraclinoid ICA or the clinoid ICA, with no communication with the ACA and with really no visible communication with the cavernous portion of the ICA. And it's very important to understand this anatomy, because I will show you in subsequent sections how these can be potentially dangerous. So here you have a CT angiogram with the carotid artery and the internal carotid artery coming off actually from the proximal part of the cavernous segment. So here you have the cavernous carotid artery. Normally the ICA would come off somewhere around here, but here you can see how it is arising actually from the distal part of the cavernous portion, just proximal to this genu. So this is a cavernous origin of the ophthalmic artery. We talked about the inferolateral trunk, and that can also give rise to the middle meningeal system. And here you have got the ophthalmic artery and supplying, of course, the orbit. But not only is it doing that, here is a lateral projection, the ophthalmic artery supplying the orbit, but a recurrent branch is supplying the middle meningeal territory So the middle meningeal has, in this patient, partly arisen itself from the ophthalmic artery. And this is an important concept to understand, because if you are embolizing a meningioma which is supplied by the middle meningeal artery, there may be a potential anastomosis with the other MMA origin, which is typically from the internal maxillary artery. And if you don't recognize this anastomosis, there is a potential that some of these particles can end up into the central retinal artery. More traditional appearances of pathology in this area, of course, the aneurysm, and probably more of this with Dr. Hilditch, so I won't spend much time. But to realize again the importance of this ophthalmic artery, this is the patient who's had treatment of the caroticocavernous fistula, where we have actually occluded the internal carotid artery. This is sacrifice of the internal carotid artery over here. So this is the internal maxillary artery, and you can see the anastomosis of the internal maxillary artery, which is a branch of the external carotid artery, via the ethmoidal branches, recurrent branches from the ethmoidal, and then subsequently these recurrent branches are then forming the ophthalmic artery, and via there they form the ICA. So the ICA distal to the sacrifice has again reformed, just to emphasize the importance of the external carotid artery system in these situations. We move on to the posterior communicating artery now. The posterior communicating artery, of course, is the big branch which comes off after the ophthalmic artery. It kind of links the anterior circulation with the posterior circulation. It links with the posterior cerebral artery, the P1 segment. And this is what we are showing. This is the clinoid process, the ICA. This is the PCOM, the very small vessel. And the PCOM itself, as we looked earlier on during our discussions of embryology, is in very much in balance. If the posterior cerebral artery is big, then the PCA does not have to be big. So in this patient, the posterior cerebral artery is probably big in size. But in this patient, the PCA is small in size, and hence the PCOM is a dominant artery on both sides. So this is a very, very dynamic balance between the PCOM and the P1 segments. Apart from supplying the occipital lobe, of course, the PCOM also supplies some parts of the internal capsule, some medial portions of the thalamus and the hypothalamic structures, as well as the chiasm. But probably the most important clinical predisposition of the PCOM vessel is when we talk about a third node palsy, like in this patient over here, either following a subarachnoid hemorrhage or spontaneously just because of the size of the aneurysm. It's important to realize the close association of the PCOM artery with the third nerve. And we have looked at this before as well when we have talked about the third nerve anatomy, as to why the PCOM artery can press upon the third nerve, either close to the origin or sometimes even close to where it's entering into the cavernous sinus. And this is just a location of the posterior communicating artery. Just beyond the posterior communicating, a very important artery, though very, very small, is the anterior choroidal segment, the anterior choroidal artery itself, which passes posteriorly again. So this is a high resolution T2. You will have seen these images when we talked about the cranial nerves, the IAMs, the vestibular schwannomas. So you have got the posterior communicating artery, and just beyond that, you get the anterior choroidal artery. So this is the PCOM, and this is just a small posteriorly oriented anterior choroidal artery. And here you have on the CTA again that same artery. So it passes through the cisternal portion, as in the suprasylvian cistern, and then it penetrates into the temporal lobe via the choroidal fissure to supply the choroid plexus of the temporal horn. So this is again variable. This is a patient who's got a small anterior choroidal artery, but this is a patient who actually has got much more bigger anterior choroidal artery. And the choroidal artery again is in balance with the PCOM, because the choroidal artery, in fact, and I have sort of passed on to this, we didn't talk about detail in the embryology, is a dominant artery which supplies the developing tectal plate and the occipital lobe in the birds. And so the PCA, in fact, is initially a branch of the choroidal, and we can sometimes see this in humans as well, and we call it the avian aspect of the anterior choroidal. But this PCA is subsequently annexed by the posterior cerebral artery, the PCOM, and hence the anterior choroidal loses that. But occasionally, like in this patient, you can see the choroidal is very big artery and will supply some part of the PCA as well. It's a very important artery. It supplies very many structures, and any tampering with this artery, this was post embolization. Unfortunately, this patient developed an infarct in the posterior limb of the internal capsule. Uh, Beyond the anterior choroidal, we then go towards the carotid termination. Sometimes we refer to as a carotid T, where the carotid artery is going to divide into the anterior and middle cerebral artery. And you can see why it's called as a carotid T, because it's kind of a T-shaped structure. You've got an aneurysm over there dividing into the ACA and MCA. And this division can be variable in terms of the equality. Sometimes the ACA can be small or hypoplastic, and that would mean that the ICA would go predominantly towards the MCA, or sometimes it can be symmetric, like in this patient over here. And it doesn't necessarily have to be a straight T. Sometimes it is quite an angle T, especially in the sagittal plane. Just to show you this this patient with a stroke over here, you can see the carotid within the neck. And just to show you the anatomy again, this is with the lateral portion, the cervical carotid artery, the petrous over here, then the cavernous, the clinoid portion is going to be here. This is the ophthalmic artery, the pecom artery. The choroidal we just don't barely see. We see some perforators coming from the pecom, and then the stump, where the occlusion has occurred in the part of the artery between the pecom and the carotid T. And again here as well, what we are seeing here is the pecom, which is opacifying. So there is no opacification beyond the pecom, and this is after recanalization. Just to show you the anatomy has regained itself, what it should look like after recanalization. So this is kind of the normal appearance of the carotid T. Moving on intracranially now towards the anterior cerebral artery and the middle cerebral artery. So the anterior cerebral artery is the smaller division, but it used to be the more dominant division. We have looked at this during embryogenesis, because MCA is actually developed much more later on as merely a offshoot of the ACA of the striate branches, as the superolateral cortex started to develop much more dominant. And though it looks bigger, it is much in a sense a derivative of the striate artery itself. The ACA, the A1 segment, is usually very small, and we'll talk about the segments in a minute, but it has this peculiar course which occurs above the optic chiasm. So typically the A1 is suprachiasmatic. Sometimes, very rarely, it can be infrachiasmatic, and it's important to identify that, especially when endovascular surgeon or a surgery has been contemplated by the transsphenoidal route to for operations around the optic chiasm or in the supracellular region. And this is another patient with a large tumor, a cystic tumor, and you can barely see the anterior cerebral artery, which is significantly stretched over the apex of this dome of this tumor, and hence much more liable to injury if not identified during transsphenoidal operations. As I said earlier, the ACA is a very variable, probably one of the commonest variations that we see. For example, in this patient over here, this is the left internal carotid artery, and you can see how the left ICA is predominantly supplying the left MCA. The left A1 is hypoplastic, and hence the right ICA, which not only supplies the right MCA territory, supplies the right ACA territory, but also supplies the left ACA territory. So the right A1 supplies both A2 segments. So what are the segments of ACA? So of course, we have got the earlier one, the A1 segment, which is from the carotid termination up to the ACOM. Beyond the ACOM, we start getting into the A2 segments, which is the proximal part of the ACA up to the pericallosal arteries, and beyond the pericallosal arteries, we talk about the A3 segments. What I have tried to show over here is the importance of the ACA. The ACA is of such a paramount importance of this area, which is close to the septum pellucidum, which is called as a subcallosal area, also very close to the optic chiasm. And this area is supplied by the ACA, the chiasm, the subthalamic area, the parts of the anterior hypothalamus, and this part of the brain, which is called as a preform cortex, which is also supplied by parts of the ACA itself. And hence any damage to this area, for example, after ACOM hemorrhages, will lead to profound effects on the patient's personality, on the person's sense of smell, and also can be epileptogenic as well. And this is the relevance of that A1 segment. Another important branch of the ACA is the Huebner artery, and we hear about this talked about a lot in anatomy as well as in surgical literature. And it's probably a very dominant perforator artery which arises from the ACA, usually typically from the proximal ACA, sometimes from the A1 segment, sometimes from the ACOM, or sometimes from a very proximal A2 segment as well. And it's a very dominant perforator which then supplies part of the caudate head and the adjacent globus pallidus. It's very, very important to identify this recurrent artery of Huebner during surgery and also during endovascular procedures. And this is just to show you on this time of flight MR angiogram, the small recurrent artery of Huebner, which then courses to supply this part of the caudate and also of the medial aspect of the globus pallidus. Unfortunately, this patient had sustained infarction in that area. Coming back to the segments, so you have got a A1 segment, then the A2 segment, which is principally the pericallosal, and this anatomy again is very variable in within us. Necessarily does not happen have to happen in the same way. So the pericallosal artery here, you can see it continues posteriorly over the corpus callosum, then subsequently forming the A3 and the A4 segments. And the rest of the frontal lobe, the dominant arteries are the and are the callosomarginal arteries, the frontopolar arteries, which are here at the frontal pole, and of course more posteriorly you get into the paracentral area, uh, which is uh, which is around the central sulcus, and most posteriorly you get up to the precuneus, which is the branch which goes just in front of the parieto-occipital fissure. So these are kind of the branches of the ACA. These are the cortical branches, but also important to realize, as we looked earlier on, are the perforator arteries which we don't see. uh, and this is these are the some of the clinical sequelae. This is a patient with a pericallosal aneurysm which has ruptured, and you can see the hematoma is much more higher up. It's going to be in this distribution, and it's not going to be at the base. So in someone with the hematoma adjacent to the corpus callosum, the hunt for the aneurysm has to be higher up. And if the CTA does not include this area, we have to ensure we repeat the CTA to include this in the acquisition. And this is the patient with infarction within the pericallosal territory. Moving on to the MCA, as I said, MCA much more later in evolution, arising as a lateral offshoot, if you like, of the ACA itself. Again, very variable in terms of its appearances and its divisions itself. It lies within the sylvian fissure. We have looked at the anatomy of the sylvian fissure. We have got the deeper aspect and the more superficial aspect of the sylvian fissure. So this is a angiogram to show the anatomy of the MCA. We talk of the M1 segment, and again, that is very variable. It's important to recognize the length of the M1 segment, especially when contemplating surgery, because a short M1 segment would mean that the aneurysm or the MCA bifurcation is going to be quite deep from the skull vault itself. So it's important to recognize and communicate with the treating physician how the M1 segment looks like and what is its length. In terms of the branches, we'll look at the cortical branches a bit later, but again, important to realize all these lenticulostriate branches which arise from the MCA, and they are organized themselves as the medial and the lateral lenticulostriate branches. So medial, of course, arising from the A1 segment as well. We have looked at the Huebner branch, but also arising from the MCA, supplying the medial and the lateral aspects of the lentiform nucleus. Subsequently, the MCA comes out uh, towards the sylvian fissure over here, and then takes this characteristic sharp turns along the superior and also occasionally along the inferior lip, and these are along the opercula of the frontal and the parietal lobes. And this from here, so this is the M1 segment, this is the MCA bifurcation, these are the M2 segments, and as soon as they hit on the surface, we would call them as the M3 segments, and much more further distally, we call them as the M4 segments. And the MCA branches are again labeled according to what they are supplying. We have got the ascending or the anterior frontal, which is also partly supplies the Broca's area. Then you've got the precentral, the central, and the post-central arteries. And on the left side, you of course have the angular artery. And we have looked at this anatomy when we looked at the angular gyrus, and finally parts of the temporal lobe can also be supplied much more posteriorly, typically by the PCA territory, but certainly the anterior is supplied by the anterior and middle is supplied by the MCA. So this is again to emphasize the vascular anatomy. So this is the M1 segment. This is the M2 segment over here, and then as soon as it starts coming out, we reach into the M3 and subsequently the M4. And this is a surgical slide to show again the same anatomy and the relevance of identifying that M1 segment, the length of the M1 segment, because that is where the surgeon may have to reach up to or the proximal carotid to obtain any control prior to operations more distally. And this is a DSA to mimic the the slide here to show you the various branches of the MCA: the frontal branch, the operculofrontal branch, the precentral, the central, and the angular branch. And these kind of mimic the gyral anatomy itself. And if you try and understand this kind of triangle, try and look for this triangle, which is the Sylvian triangle, to understand the anatomy of the MCA, with the anterior most forming anterior and inferior most forming the orbital and the orbifrontal, and the posterior most forming the posterior temporal and the angular branches. And these are again the MCA segments, looking at them on imaging. So these are the perforators which are supplying the perforating from the base of the brain and perforating the striate territory over here. And this is again to demonstrate the M2 segment as they come out or on the surface of the insula and then coming out over the frontal operculum to become the M3 segments. And this is a patient who has had a stroke, and you can see the occlusion of the artery, but in spite of that, there is perfusion beyond that artery, suggesting that this is that the collateral circulation is quite reasonable in this person. And again, just to identify the MCA within the proximal Sylvian segment with the hyperdense appearance over here, with the clot within that artery itself. And this is a patient with infarction developed as a result of occlusion of the lenticulostriate branches of those arteries. And again, on angiogram, we can see these perforating arteries. These are the perforating arteries which are arising from the MCA on the coronal views. On both sides, you can see how they perforate and reach quite high up to almost up to the level of the roof of the ventricle. And hence, if you have got an AVM quite high up, sometimes you can see how they can be supplied by the perforating branches of this anterior and the posterior circulation. These infarcts doesn't necessarily have to be because of atherosclerotic disease. This is a young child who's developed an infarction within the posterolateral putamen over here. And to highlight that, yes, we do see the stenosis. So this is a circle of Willis. You can see the left MCA. You can see the right MCA, which is stenotic. But this is a vessel wall imaging appearance where you can actually see the enhancement within the wall of the internal carotid artery. So this is vessel wall imaging, which we sometimes employ to look at the enhancement within the wall of the vessel and try and understand what is the cause of infarction. And these are some other example of perforator strokes. In this is the patient with tuberculosis, and you can see how the enhancing granulomas are affecting the vessels and causing thrombosis of these perforating arteries, giving rise to infarction. Aneurysms can of course form distally as well, and this is a much more distal part of the this is the Sylvian point of the MCA, and you can see more distal aneurysms. Typically, if you see them, you should think about mycotic aneurysms. Before moving on to posterior circulation, I know we are going to overshoot. I will need probably about another 15 minutes. Are we okay to carry on here?
Yes, Dr. Herwadkar, no problem.
Yeah. Before moving on to the posterior circulation, thank you. I just want to sort of share my thoughts on the circle of Willis. We haven't really talked about the circle of Willis. The circle of Willis is, of course, a complete circle, as we would imagine, which is rarely the case. You see a complete circle in less than 25% of cases. And what is it formed by? It's formed by the internal carotid artery from both sides, the anterior cerebral artery from both sides, the A1 segment, the ACOM. So that's the anterior aspect of it. Posteriorly, you get the posterior communicating arteries on both sides, which join together with the posterior cerebral arteries, which come from the basilar artery. And basilar artery, of course, is formed by the vertebral artery. So the circle of Willis is itself formed by the ACA, the carotid, the PCOM, and the PCA. So that's the circle of Willis. And those are the derivatives of them. And this is a picture of the CTA angiogram to show you. So this is the carotid artery here coming here, just medial to the clinoid process, moving laterally the MCA. Similarly, this is on the left side. You can just about see the ACA. This is stenotic, but left MCA. And you don't really see the circle of Willis completely because it's such a thick slice. And here is an incomplete circle of Willis. These are the two carotid arteries on each side, medial to the clinoid process. This is the MCA. This is the ACA coming here. And this is the communicating segment, ACOM segment over here. And this is the left PCOM, which is communicating with the left posterior cerebral artery. And you can see how the circle is incomplete because there is no right PCOM on this side. And you can see how the right P1 is slightly bigger as compared to the left P1 because the right P1 has to supply the PCA territory because it does not have the PCOM to do that job. And this is an incomplete circle of Willis. You have got the MRA over here. You can see the MCA on both sides, the carotid artery, the ACA, a dominant ACA on the left side, a smaller ACA on the right side, but there are no PCOMs, and hence the basilar termination is going to supply both PCAs and then the occipital pole. So that's a circle of Willis. So let's look at the posterior circulation now. What are we going to look at in the posterior circulation? Okay, so we're going to look at the vertebral arteries. We're going to look at the basilar artery and of course the branches of each of them. And we have looked at this before on the CTA and on the MRA to look at the origin of these vessels from the neck, which can be elegantly shown on as you see on this CT angiogram. The left vertebral artery arising from the left subclavian, the right vertebral artery arising from the right subclavian. Of course, you can have variations where the left subclavian artery can arise directly from the aorta. And when we talk about the segments of the vertebral artery, you have got the V1 segment, which occurs from the origin up to the point where it enters into the vertebral foramina, typically at C6 level. And from then we get the V2 segment till up to the C1, C2 level. And then beyond that, the vertebral artery arches at C1 level and penetrates the head at the level of foramen magnum. So that becomes a V3 segment. And then subsequently the intracranial segment from the point where it has penetrated up to the vertebrobasilar junction, which becomes the V4 segment. And these are the various parts of the vertebral artery, and each one of them are prone to specific diseases. And we'll look at them in a minute. Okay, so if you look at the branches of the vertebral artery, I'm going to ignore some of the neck branches because they tend to be the muscular branches. They are of course important, but not relevant so much for our discussions now. But the most important branches of the anterior cerebral of the vertebral artery are the posterior spinal artery from the top, the anterior spinal artery will join up together to form the single anterior spinal artery, and this will perfuse the upper cervical cord. The left pica, the posterior inferior cerebral artery, smaller medullary branches, and the meningeal branch of the vertebral artery. So these are the branches of the vertebral artery. And just to share some pathology over here. This is the cervical course of the right vertebral artery, and now you'll have picked up the abnormal flow void. You've got a normal flow void, the black area here. The white area is abnormal, and that is because of the hematoma, the dissection within the right vertebral artery. And these dissections can occur at 2 points. One, if I were to just go one step back, it can occur here where the artery, from being relatively mobile to a fixed position, so it can occur here. And the second portion is where it can change the direction from the V2 to the V3 portion. So these are the two vulnerable areas of the vertebral artery, and this is one vulnerable area. And here you can see this is the MR angiogram of the same patient. This is the left vertebral artery, and you can see the change in caliber of the right vertebral artery as it is changing from V1 to the V2 segment. So this is where it is likely to be entering into the vertebral foramina. And the other point, of course, is where it is swinging over the C1, and that's the other vulnerable point, as I said, from being fixed to being a mobile segment. And this is again another patient with a hematoma within the wall of the artery. This is the normal right vertebral artery. This is the abnormal left vertebral artery with infarction within the posterior lateral medulla in that patient. Uh, the artery is also vulnerable within the neck, and certainly following fractures. This unfortunate patient has developed basilar thrombosis, and you can see what has happened in this person over here. They've got a screw which has traversed into the intervertebral foramina, which has resulted in thrombosis of that artery with subsequent embolism into the basilar artery. So this intervertebral the segment usually is fixed within the foramina, but sometimes, especially in trauma, it can be affected, significant violent trauma, if the fracture is involving the artery, or occasionally, or hopefully rarely, in such circumstances. Uh, this is another patient, an endovascular complication. You can see the dissection within the left vertebral artery. You can see how it is fusiform, enlarged, irregular. This is the right vertebral artery. But what you should also appreciate is the spinal artery which is arising. Unfortunately, dissections are very difficult to treat. One of the ways to treat them is by sacrificing that segment. So this has been sacrificed, but what it has led to is occlusion of the anterior spinal artery, resulting in spinal cord infarction of the upper cord and medulla. Other diseases, of course, you can get stenosis within the right vertebral artery, and that can cause infarction. So this is stenosis within the distal part. So V4 part of the right vertebral artery, you can see here, quite badly stenotic and atherosclerotic. So moving on to the branches now. We have seen the anterior spinal artery. A very important branch is the pica, the posterior inferior cerebellar artery. It's one of the arteries which supplies the cerebellum. The artery's name is a bit of a misnomer because it's not just the cerebellum. It supplies some very, very important structures on the brainstem, especially the lower medulla. The pica, like other arteries of the cerebellum, is very much in hemodynamic balance. So the cerebellum itself is supplied not just from the pica, as I've shown here, but also from the anterior inferior cerebellar artery or from the superior cerebellar artery. And the dominance of one vessel will lead to regression of the other vessel. So for example, over here, they are quite dominant, co-dominant on each side. So you can see that the pica is relatively small in size, whilst in this patient you can see that the left pica is almost absent, but the left ica is quite dominant and is likely to supply the pica territory. Whilst on the other side, you can see that the pica is quite dominant, but the right ica is quite small in size. So this is kind of a hemodynamic balance which occurs in these situations. It's important to realize that. So in terms of the anatomy of the pica, it's got these various segments, and I've borrowed this from the literature just to show you the various segments in relation to the medulla oblongata, in relation to the cerebellar tonsil. So you have got a segment of the pica which arises just in front of the medulla, is called as the premedullary segment or the anterior medullary. Then it becomes a lateral medullary segment, and then it takes a hairpin bend downwards. And at the apex of this bend is a cerebellar tonsil. So this is what we call as a tonsillar loop of the pica, and it comes back on itself, reaching very close to the floor of the fourth ventricle, beyond which it then divides into the vermian and the hemispheric branches. In terms of the functional importance of this, the pica supplies a vast territory of the posterior and lateral medulla from these segments. If there is a disease much more distal, and if you have to treat by obliterating that vessel, if that obliteration is anywhere distal beyond this loop, then the likelihood of causing damage to the brainstem is much more less. So just to show you the anatomy again here, this is a right vertebral artery, left vertebral artery on the CTA angiogram. You can see the brainstem over here, and this is a branch of the pica which has come off, and a small portion which goes through the foramen of Luschka, supplying the Vermian branch. So this is a Vermian branch over here on the AP, and this is on the lateral. This is just to show you the vertebral artery with the origin of the pre-medullary or the anti-medullary segment of the pica. And this is just to go much more deeper inside now, and you can see behind at the level of the floor of the fourth ventricle, the pica itself with the tonsillar loop, and then subsequently the hemispheric division over there, and the Vermian division. So it's important to try and trace out the pica when you're looking especially for blood within the fourth ventricle. If someone has got intraventricular blood in the fourth ventricle, it's not important just to identify the vessels of the circle of Willis, but also look for the origin of the pica from the vertebral artery, but also look at the more distal pica, because the aneurysm can actually be much more distal on the pica itself. Some examples of diseases of the pica. Here you have got the left vertebral artery, which is atherosclerotic, and origin of the pica is involved, giving rise to the infarction. This is another patient with the dissection of the left vertebral artery and the pica. You have got this classical, what we call as string of bead appearance of the dissection involving the pica. And this is another patient where you can see on the lateral view why the inferior posterior medulla can be involved if there is occlusion of the pica along with the inferior aspect of the cerebellar artery. So this is patient with Wallenberg syndrome resulting from pica occlusions. I was talking about the looking for distal aneurysm. So this is a patient with a Vermian hematoma, also had a fourth ventricular clot, and you can see how the aneurysm is much more distal rather than the more traditional aneurysms that we are accustomed to seeing much more on the surface of the brain, if you like. But this is where you have to realize this aneurysm is much more distal, and if it's much more distal, for example over here, as you can see, it's much more beyond the tonsillar loop, and hence the likelihood of damage to the much more vital centers within the medulla are going to be spared, even though they are probably likely to get some degree of infarction of the cerebellum. So this is sacrifice of the small artery over here, but with preservation of the more proximal tonsillar loop of the pica. Beyond the pica, of course, we get to the basilar, which is formed by the confluence of the two vertebral arteries, and the basilar will supply the vast of the brainstem via the perforators, and of course, it also has the two other dominant cerebellar arteries, the ICA and the superior cerebellar artery. The basilar perforators are numerous, and you can barely see them on an angiogram, but on a good quality CT or an MRA, sometimes you can see these perforators which come off from the posterior aspect of the basilar artery and perfuse into the brainstem. Similarly, from the other basilar perforated territories from the basilar termination. So this is a basilar termination with the posterior cerebral artery, and from here you get perforators which perforate superiorly and go and supply the thalamus and also posteriorly to supply the midbrain. And these are the perforators from the basilar termination. And these are some of the sequelae of the occlusion of these perforators. This is a basilar perforator stroke. You can see how the midline is respected, because these perforators typically will supply 1/2 of the brainstem at that level and can result in strokes in that territory. A moment to just talk about the perforators which we talked about from the basilar termination. These perforators will supply the thalamus, will supply part of the midbrain as well, and usually they come off from the P1 segment of the basilar termination. Very occasionally, you can have the perforators which come off from only one PCA or predominantly from one PCA, and then that artery is called as the artery of Percheron. And what it does, that this artery will then supply both medial thalami and both sides of the upper midbrain. And if you have got a thromboembolic occlusion of this vessel, it can result in thrombosis of both thalami or of paramedian midbrain. So this is the occlusion of the artery of Percheron, giving rise to this appearance. Beyond the perforators, we have the anterior inferior cerebral artery and the superior cerebral artery. So the anterior inferior cerebral artery, as said, it is very much in hemodynamic balance with the pica. This is a pica over here, and this here is the ICA, anterior inferior cerebellar artery. It's a fairly long artery because what it has to do, it has to go around the pons and then supply some of the pons, some of the middle cerebellar peduncle, but then subsequently it has this sort of a loopy appearance which it does at the level of the internal auditory canal, because not only does it supply the pons, not only does it supply the middle cerebellar peduncle, but the labyrinthine artery also comes from the anterior inferior cerebellar artery. And just to show that example over here, this is the basilar artery, the vertebrobasilar junction, the basilar termination. This is the left ICA over here, the right ICA, anterior inferior cerebral artery, which is occluded here, unfortunately, and you can see the stroke which has resulted as a result of that. These patients can develop various symptoms. Apart from motor symptoms, they can also develop trigeminal symptoms. Remember the anatomy of the trigeminal nucleus, the tract which can come off from that area, but also involvement of the vestibular cochlear nuclei, but also involvement of the labyrinthine artery, which is a branch of the ICA. So they can get hearing problems or vestibular symptoms. Reaching up to the superior cerebellar artery, which is just below the basilar termination. So you have got the basilar termination with the PCA, and these again are very variable. Sometimes they can be duplicated. For example, over here, sometimes they can actually come as share a common origin with the PCA, or occasionally they can be seen as separate arteries by themselves. They are prone to aneurysms because of this disposition. If the anatomy is curious, like in these examples, you can get aneurysms from the superior cerebral artery, and of course the infarction of that artery is going to affect the brainstem, which is supplied from the superior cerebellar, especially the inferior aspect of the midbrain and the superior cerebellar hemisphere, as in this patient, where the superior cerebellar not only supplies the cerebellum but also supplies the midbrain, typically the dorsal aspect of the lower midbrain. So it's important to realize that the cerebral arteries not only supply the cerebellum but also supply the brainstem. Finally, when we talk about the basilar termination, the basilar termination is where the basilar artery divides into the two posterior cerebral arteries, and this is the more typical textbook appearance, where you have got a superior cerebral artery, which here it's coming off from the basilar artery, but here it's sharing a common origin with the PCA, and you have got a basilar termination, which can be sometimes flat, sometimes can be more V-shaped, or sometimes can be like this, where the PCA is actually absent. And from our previous discussions, you will immediately realize that if the left PCA is absent, this patient probably has a dominant left PCOM or a fetal left PCOM, which is going to supply that left posterior cerebral artery territory. And hence the basilar artery will have these various appearances based on how the basilar termination itself has fused, and whether the PCA and the superior cerebral artery are arising separately or are arising in this fashion. Other important point to realize is that if the posterior cerebral artery is dominant on one side, that is of course going to be the location of the perforators. If the PCA is small or actually low lying, then it is less likely to be supplying the perforators of that side of the brainstem. Finally, moving on to the posterior cerebral artery now. The posterior cerebral artery arises from the at the basilar termination, as we have looked at, and it shares some of its contribution also comes from the PCOM. And we have looked earlier on how the PCOM actually perfuses the top of the brainstem up to the early mammals. It's only in later phylogeny that the PCA and the basilar termination gets antegrade flow from the vertebral arteries. So this is the PCA with the various segments. The P1, which is the part of the PCA between the basilar artery to the PCOM. So just this small portion over here. Subsequent to that, the PCA is going to swing around. So the PCA is going to swing around the brainstem, and as it's swinging around, we call it as a P2 segment, almost up to the posterolateral margin of the midbrain. Beyond that, we call it the P3 segment. Up to the origin of the parieto-occipital branches. So these are the P3 segments. And after that, you get the cortical branches, which are the P4 segments. So what are the branches of the PCA? Again, we know it supplies the occipital lobe, but also important to realize that the PCA supplies a vast territory of the perforator territory of the of the thalamus, and also the choroidal vessels. We have talked about the P1 artery perforators. We have talked about the artery of Percheron, but also you have got other branches which are called as the thalamoperforating and the geniculate branches, which will supply, and these are the small wisp-looping perforators which are going to supply the thalamus and the upper midbrain, which are coming from the P1 segment. Similarly, you have got the arteries which come off from more distally, which will supply the choroidal posterior choroid, which will go up to the into the roof of the third ventricle, and then subsequently they will supply the parieto-occipital branches and some of the posterior temporal branches as well. And this is what it looks like on a normal angiogram. This is a lateral view of the vertebral artery. You've got the pica here. This is the occipital bone. Anterior is here, and you can see how the posterior cerebral artery then swings around. This is going to be the P1 segment. This is going to be the P2 segment, and then the P3 segment, where it's then dividing at this level into the calcarine and the parieto-occipital branches. And these wispy vessels here are the perforating arteries which are going to supply the thalamus in that location. This vessel here is actually the posterior choroidal artery which enters into the third ventricle and supply the roof, the choroid within the roof of the lateral and the third ventricle. And this is a patient with a vascular malformation over there, partially treated, and you can see the enlarged choroidal artery. So you've got the smaller wispy looking perforating arteries, and this is a much larger posterior lateral posterior choroidal, which is then supplying this vascular malformation. And it's important to identify this because this is where the anastomosis between the anterior and posterior choroidal occurs, somewhere around the level of the foramen of Monroe. And this patient with infarction, just to identify the occipital lobe infarction in a different patient. So not only do we have the cortical branches, but it's important to realize that the PCA also has very important perforated branches supplying the thalamus, the posterior limb of internal capsule, and the upper midbrain. And this is to share that philosophy again. Not only the PCA infarcts affect the occipital lobe, but also affect the thalamus and the internal capsule. This is a MR scan, and this is to show you SWI image with the thrombosis which is occurring within the left PCA, which has resulted in infarction of these territories. And just the final two slides. I know we are about 20 minutes already beyond. There are these embryonic anastomosis between the anterior and posterior circulation, and the one which we talk about commonly is the posterior communicating artery, which communicates with the from the carotid with the P1 segment. But there are other anastomoses. For example, here we have got a persistent trigeminal artery, which anastomoses with the cavernous portion of the internal carotid artery and the basilar artery, which is shown over here. Remember, this is from the cavernous portion of the internal carotid artery with the basilar artery, whilst here this is the supraclanar portion of the PCA of the carotid, which gives rise to the PCOM. So that's a PCOM which is on this part of the supraclanar part of the internal carotid artery, which is this part, while the persistent trigeminal is much more proximal from the cavernous portion. And this is a much more rarer example. We have seen this before, where there is an established communication with the vertebral artery and the carotid artery. And this is the hypoglossal artery through the hypoglossal canal. I mean, these are very, very uncommon. PCOM, of course, is common. Persistent trigeminal, not so uncommon, but this is very rare. But what is much more relevant and much more important in our day-to-day life, especially for someone who's practicing endovascular treatment, is to understand the anastomosis or the potential anastomosis between the external carotid artery branches and the internal carotid artery branches. And we haven't really talked at all about the external carotid artery, but the external carotid artery has a very, very significant contribution, not only in perfusing the cranial nerves, but also whenever there is occlusion. For example, here you can see the internal maxillary artery. Here there is no internal carotid artery branch. Internal maxillary is a branch of the external carotid, and you can see how it is forming a collateral flow via the ophthalmic with the internal carotid artery. And this is that same ophthalmic artery over here, and this is the internal carotid artery. So this is a potential anastomotic site. These are some other potential anastomotic sites between the carotid artery. This is the median branch of the carotid artery with the ascending pharyngeal branch of the external carotid. And this is another similar anastomosis between ECA and ICA. This is the left vertebral artery, which you'll have recognized with the opacification of the occipital lobe. But what we are seeing here, this is the occipital artery. So this is an anastomosis between the occipital artery and the vertebral artery, which is a very important anastomosis to understand, because sometimes if you are embolizing in the occipital artery territory, there is a potential that the embolic agent can extend into the pica territory or into the vertebrovascular circulation. So it's important. We haven't really touched upon the ECA at all, but the ECA has very significant, important contributions towards perfusing some of the nerves, but also important to recognize them for the potential dangerous anastomosis, which is really a tiger territory when you are embolizing these areas. I think I will stop there now, and I will take any questions on these discussions. I think next week or next episode will be on the venous anatomy. So thank you.
Thank you, Dr. Herwadkar. I think we can later on, if possible at all, can touch up on the ECA bypass. However, if there are any questions from anyone, you can unmute yourself or use the chat box. Or if there is not, then we can call it a day.
Yeah, thank you. Thank you so much. So next week we will discuss, I think, the venous anatomy and the sinus anatomy. Again, something which is very close to my heart. So thank you, friends. Bye-bye.
Thank you, Dr. Herwadkar. Thanks everyone for joining. See you next week.